Uh, Thanks for letting me present here. My name's Todd Ponsky. I am a pediatric general surgeon, general and thoracic surgeon, and I also happen to be the Chief Innovation Officer at Cincinnati Children's Hospital. And my focus in my life has been academically how we could probably do a better job getting information to the world. That in healthcare, we have never been on the forefront of knowledge dissemination, and we could do a whole better job of getting information to the world. And the whole thing started actually going back to 2008. And in 2008, I was giving a talk in Uruguay, and I was giving some talk on some fancy surgical procedure, and someone stood up in Spanish, and he said, "Sir, thank you for this talk on this advanced surgical procedure, but we don't even have like textbooks that are anywhere close to what you're using because we have to wait for translated text." It hit me like a ton of bricks. I flew home and I asked my members of my lab, "Are you okay if we refocus on education?" They all said yes. And our mission is to democratize knowledge. Our goal will be, can we figure out how to equilibrate information as soon as it comes out so everyone in the world, no matter where you live, gets updated information to improve care for children? So if you look at healthcare, there's going to be disparities. I mean, not everyone's going to have the exact same equipment. Not everyone's going to have these fancy instruments. I get that. But it is unacceptable to think that in 2025 that our knowledge isn't equal. That's crazy. And so we have to do a better job in healthcare because we stink about getting information to the world. So we created a moonshot, and this is part of the moonshot created at our hospital to say that by 2035, all pediatric providers around the world will have free access to comprehensive pediatric medical knowledge. Free and current. Now, a moonshot is when you come up with an idea. I don't know the actual definition. This is what I think. A moonshot is when you come up with an idea and everyone thinks there's no way to do it, but you think you have a trick up your sleeve to do it. That's why it's a moonshot for us. So let's talk about how do we currently share medical knowledge. This is what we do. Textbooks, journals, and societies. And you notice how I put the pictures in black and white to try to make a point. These do not work anymore. These used to work. They actually were very effective, not only to establish credibility because of peer review, but it was the best way that when you published some great paper to tell the world about it. It's not effective anymore for visibility. It's good for credibility, not visibility. This talk is a much shortened version. I can go into explain it offline if you want to know, but there's a lot of nuances as to why they don't work. But let's take one for journals. Journals is where the best stuff is published. Here's the problem. When a paper comes out that should be changing the world, that same day, 1,000 other papers come out in that same topic because there's no filter anymore, because we have predatory journals, we have a million things. And so now, how do you know what to pay attention to? There's no way to filter through the content to know when there's something to pay attention to. In fact, look at this. Exponential growth of medical knowledge. This is crazy. This means, so in 1950, it took 50 years for medical knowledge to publish. Now 73 days. That is right. That means that if you're practicing healthcare, the amount of information you're supposed to know doubles every 73 days. And that was back in 2020. So I bet you it's less now. So there's just no way we can keep going on the way and thinking that everyone's going to stay current and everyone's going to practice the best medicine. It's not going to happen. Now you say, so what? Exponential growth, it doubles. Who cares? Here's a fun little example to show you the power of doubling. Once upon a time, a man invents a chessboard, and he takes the chessboard to the king of India. And he says, "King, I invented this amazing chessboard. What? It's amazing." And the king goes, "Oh my God, this is the best game ever. What can I do to repay you?" The man says, "I don't want money. I want rice." And the king says, "How much rice do you want?" And he says, "Let's play a game. Let's put a grain of rice on the first square. Then the second, we'll put 2. Then on the third, we'll put 4. And we'll just keep doubling." And the man says, "Ha, The king says, no problem. We'll get 1, 2, 4. And he realizes when he's doubling, the second row, a big number, when it doubles, becomes a really big number. And all of a sudden, the room they're in fills up with rice. Then the palace fills up with rice. And then the entire country of India fills up with 3 feet of rice. That's exponential growth. So when we tell you that medical knowledge is doubling, it's no joke. Like, it's a big number. 18 quintillion, by the way, if you were counting. So my dad would say to me, come on, wimp. We did this, no problem. And I'd say, yeah, but Dad, this was you. You were on the first half of the chessboard. This is us now. We are now in a new era. So we have to rethink how we're going to get knowledge around the world. How do we get exponential growth into, as like I said, I'm a surgeon. So I'm busy in the operating room. How do I get information into my brain? I have no time to be reading exponential growth and knowledge. What if we could do this? What if I wake up and you just like, here you go, pediatric surgery, enjoy your orange juice and your pediatric surgery, and you're good. That would be amazing. I know pediatric surgery. That would be the answer. But we can't do it yet, although Elon Musk is working on neural lace, which theoretically uploads and downloads your thoughts. And by the way, it seems to be working, that you can upload and download your thoughts. They're doing it in monkeys. The monkeys are killing each other. That's one downside, but it is seeming to upload and download their thoughts. It's crazy. All right. So until we can upload and download our thoughts, what can we do now? We have to stop fighting it and join the crowd of how people are getting information. How are our kids getting information? Media. They're getting it from video. They're getting it from audio. They're getting it from social media. And we've been fighting it in healthcare because we're not fun. We're not engaging. We're not good at video. So we just go and give boring lectures. This is what we need to be doing. Because during the pandemic, when there was tons of misinformation, we lost out because we don't know how to make engaging content. Bad information has great content. Good information does not. That needs to switch. So
as you can see,
this is an example of a boring lecture.
As you can see from the data, the incidence of postoperative infection remains a significant concern.
See the people getting up in the back? By the way, I made that video on VO3 in Google Gemini. You guys should try it. I just said, make me a boring video of a guy giving a lecture in medicine. Boom. This is what we want it to be instead.
We can see these cells migrating along these pathways, making their way to the target organ.
Make it engaging. Send it to the world. So this is what our lab does. We take important information. Now, how we determine it's important, we don't have time for this talk. That's another half. We use incredible ways of figuring out what is critical, but then we convert it into media to disseminate it around the world. And what we call this our engine, we take important stuff that's not going to be read by everyone and make it watchable, make it shareable, make it engaging, and then send that out through every social media channel we can. Now we're doing what our kids do, and the world is seeing it. So we take 3 sources of content: books, journals, and lectures. When you take a book, it's foundational information. And what we do is we say, all right, we're going to teach how to do this operation with claymation, or we're going to make a chalkboard explainer. Do you know, it's crazy the number of people that watch these. We're reaching people. We're teaching people because we're engaging the side of edutainment, right? And we're following the patterns that we know works with social media. These, oh man, these are article summaries. These blew up. If an important article comes out, the attention span of the world today is like a minute. So what we do is we say, here's an article, here's a 1-minute summary of what you need to know, and these blow up. We get thousands and thousands of views every time we put out an article summary. What about lectures? This kills me. At Cincinnati Children's Hospital, we have 600 lectures a year. People come and visit. They're the most expert in their topic. And if you're not in the room watching it, no one ever watches it again. And even if we did, if we recorded it and shared it, no one watches our videos anymore. They need to be reproduced into a way people will watch it. Make it shareable. This is incredible, important new information. Convert it to something that people will see and send it to the world. So that's what we do. And we don't just guess, we learn from experts about how to do this. We make engaging narrated videos that take an hour into 7 minutes. And We have residents and fellows and trainees from all over the world that participate with us. They just join our team to help us convert boring to engaging and shareable content. By the way, we do this legally. Fair use guidelines, there's a way to summarize an article and actually do it in a legal way to give the information but not hurt the original source. In fact, the journals love us because every time we convert an article into a video, they get 27% increase in clicks. So everyone's happy. The world's getting updated information and the journals are not upset at us. So this works. Did it work? I'm a pediatric surgeon. Guess what percentage of the world in pediatric surgery watches our content? 90%. 90% of the globe. You don't think that? So now we know it works. Now we have to do it everywhere, right? This concept works. Here's a video of me summarizing an article. My resident was presenting at our surgical meeting and got 250 people in the audience. I did this video and had 50,000 the next day.
Today we're going to address a hot topic of debate in the operating room, which is the safest headgear to wear in the operating room. Is it this? Is it this? Or is it this? Well, this question was just answered in a recent study called Hats Off, a study of different operating room headgear assessed by environmental quality indicators. The first author...
Okay, here's the problem. This looks like fun video. It reached 1 million people. But remember, I have a full-time job. So this is what actually happened behind the scenes.
Is it? Okay. Is it this?
Okay. So yes, it was engaging. Yes, it reached people. Yes, it made a huge impact. Hospitals started changing their hat policy from this video. But it took me forever. And then we had it, so it's not practical. So how are we going to do our moonshot of every day pushing out everything that's going to reach people? It's going to be engaging. It's going to be shared. And I have to make it, there's just no way. So how do we do this at scale? Now this part's controversial. So push back, but what if I tell you that this is our process? An article is identified. Again, we don't have time in this talk to go over it, but it is identified to be good, quote unquote. Important, quote unquote. Then I have our team of medical writers that convert it into a script. We have a template of what we do to make it into an engaging script. Then a moron like me gets up in front of a camera and takes a video. And then we have an editor that edits it. And then we push it out on social media. It takes weeks. What if we remove most of it and use AI? Controversial. Remember, it has to keep up all the things though. Engaging, real, blah, 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 blah. This video you're about to watch is not me. It looks like me. This was 1.5 years ago. I can tell you we've made a whole lot of progress since this video. I took a note of what's called an operative report. It's a note that gets transcribed after I do an operation. I just took the op note and I said, make this into a teachable video.
The steps of the TEF repair are the same. I tend to divide the azygos vein just to get it out of the way, but a lot of people don't. Then you ligate the fistula.
So that was Avatar. That was not me, totally just done. I just uploaded my op note, said make a video. Okay, that was 1.5 years ago. You can imagine how good it is now, and I will, maybe if we have time, I'll show you. Now, remember, the world, we said, we want to reach the world, not just United States. So that means we have to do something else. So the next 30 minutes, on top of what that took 30 minutes, another 30 minutes instead of 3 weeks, we did this.
خطوات إصلاح TEF هي نفسها. أنا أميل إلى شق الوريد الأزيجاوي فقط لإبعادي عن الطريق. 然后接扎铝管移动上层凿口袋，并且除凿口袋的剪短。Y luego utilizamos una anastomosis de una sola capa de 4 o 5 𝗧𝗍𝗶𝗄𝗃.
We're reaching the world. We are reaching the world. We are gonna change pediatric care, okay? Now we can take any website. This video is crazy. Watch this video. This literally was done with a multitude of multiple different AI tools. Now our team, we have a guy on this call who is the brains behind everything, who's hiding behind his camera, 𝗵𝗫 who is the brilliance behind this all. He, right now, we want to be able to triangulate every software. So Rami and I and others meet every week because that's how fast AI is updating. We cannot just say, oh, we'll use this for the next 6 months. In a year, each month we change. So what we do is we triangulate by getting smart people like Rami. This is taking a website. What you're going to see is literally the storyline, the narrative, the stock footage, everything, me, all AI generated.
In this video, we'd like to talk about congenital heart disease, a condition affecting 1 out of every 100 infants born in the United States. Let's explore symptoms, diagnosis, and the treatment options available. A baby's heart starts developing at conception and is fully formed by 8 weeks into pregnancy. Congenital heart defects.
Again, that was a long time ago. It's so much even better now. Now, what could everyone on this call do by tonight? By the way, I'll show a little thing at the end, a QR code. We push out AI stuff for professionals every day. Like, this is something you need to know. Just social media, we push it on social media. We have this thing called Substack where we send a newsletter once a week. So every one of you on this call should be able to do every single thing you're seeing here. It is that easy. It gets a little expensive, but eventually, like, I think the university should pay for it, or you can like $20 a month for a lot of these things. This one is free, and every one of you should be doing this. So how can I tell the story about this conference? What if I create a podcast? This is called Notebook LM. I can't see your hands raised, but I'm hoping half of you at least are using this already. I use this for my kids. I upload all of their reading materials for school, and it tutors them. It gives you any way that they learn. There's a whole nother talk about how we use AI to help our kids learn and study and tutor, and it designs it for their learning abilities. It's amazing. But this is one example of what it does for my daughters when I want them to learn about the Civil War. I plug it into Notebook LM and I have it do this.
We've boiled it down to 8 core themes from the conference materials, and we have to start where, well, pretty much every professional learning discussion starts right now: AI, artificial intelligence, and crucially, the huge risks that come along with it.
Okay, let's unpack that. So, pillar 1, AI in education. We all know AI is here, but what did 𝗍𝗏𝗍 actually say about how educators are, using it on the ground?
Well, the discussion moved past the what-ifs pretty quickly. It was all about practical application.
This is
the
just
big takeaway
from
seemed to be efficiency
innovated
gains,
website,
especially in
website.
content generation and assessment design. For
All I
instance,
did
people are using.
Hey everyone, and welcome. We're here to decode the
Now it
future
makes
of
a
learning.
video.
I mean, think about it. The way we learn is changing at a wild pace, right? And for this entire explainer, we've got the perfect guide, a key event from Stanford called 𝗍𝗏𝗍𝗏. This is where all the brightest minds in education got together to basically draw us a map of what's coming next. So this really is the big question, isn't it? Are we seeing the end of the classroom as we know it? Lecture halls, rigid schedules. Are those days numbered? Well, the answer isn't a simple yes or no. It's way more complex.
So what I would tell you is, like, anytime you're trying to explain an article, anything, it could make flashcards, a quiz, a podcast, a video, and it's so engaging and it's free. Just go to Notebook LM and do it. If you follow me on any social media thing, I give demo videos of how to do it step by step, or follow Substack, and everything's in there. And we do workshops once a month. It's free for everyone about, like, the basic AI tools that everyone should be using. Now, let's go back to the main focus here. And this is where you're going to see how brilliant Rami is, 𝗬𝗏𝗏, who's on here. In medical residency, everyone learns how to do their specialty. Why is it so effective? Why is residency so effective? You come in, you spend 5 to 7 years as a surgeon learning how to be a surgeon. Why? Because you make so many mistakes, and that's how you learn. You have protected mistakes. You have your boss above you to make sure they don't go wrong, but you make mistakes. The problem with teaching is we teach, like, what to do, but that's not going to make you remember the right way. Remembering the right way is when you mess up. We wanted to figure out, how can we design education to make people mess up and learn from it? So this is why people learn in residency, the bad mistakes. You don't make them again, okay? So instead of a lecture, what if we could create something that truly makes you feel the pain and fear of making mistakes? Every year in the lab, I ask the new lab residents to come up with something new and innovative that's going to teach people better. And I have to do that because I'm way outdated. I'm in my 50s. I need someone in their, like, 20s to figure this out for me. But what is new? So they come in the lab. Rami and 𝗺𝗲𝗁, both. Rami is a ENT who is now has a PhD in instructional technology, and he's a professor at University of Utah. And he and 𝗺𝗲𝗁 were in the lab, and 𝗺𝗲𝗁's a surgeon. They said, what if we make an interactive video that would recreate real life scenarios, allow the user to choose what to do, but see the consequence of a wrong decision? And this is what we call a storycast. What they had to do is take every possible scenario you could think of and run it through algorithm after algorithm, make videos for all of these, and this is what it looks like.
Hey, there you are. I just got the call. 5-year-old male pulled from a house fire. Vitals are listed here. What should we do first? Looks like there's a pelvic fracture on X-ray. Here are the vitals. What do you want to do? All right, let's start taking out some of these packs. Do you see what I see? It looks like a splenic laceration, probably a type 1, but it's not bleeding anymore. What do you want to do? Great job. So in summary, the patient came in and you immediately evaluated his ABCs. Realizing that the airway may have been compromised from inhalation injury, you elected to intubate, and you did it. You saved his life.
Rami also said we have to have gamification. That was his thesis on gamification and learning. So it was a leaderboard. How do you compare to others who did this? And it sends your results to your program director so they can see if there's trends in how people are getting answers wrong. Then we said, can we do this live? We are going to try a fully immersive digital way of teaching that we think is starting to get us on track of how we should be teaching medical knowledge these days. Trying all new technology. First, you're going to take a quiz to test your pre-course knowledge. A QR code is going to pop up on your screen. Hold your phone up to that QR code and a quiz will download to your phone. Then, you're going to participate in a live action storycast, where as a group, you will determine the outcome of the patient. And finally, we'll play an animated video that explains everything you just learned. Rami, why don't you start the storycast?
Hey, there you are. I just saw our first clinic patient. 1-year-old male. Mom noticed an abdominal mass while bathing him. But on exam, there's a non-tender, palpable mass in the left upper quadrant. What do you want to do?
We're going to go with what the audience chooses here. So whatever the majority is what we're going to go with. And it keeps creeping up, but I think the majority are definitely going to go with A. So Rami, go ahead and take us through A.
Ultrasound shows that the mass is adrenal in origin. A CT chest abdomen pelvis doesn't show any lesions anywhere else in the body. What other tests do we have to get?
All right, so in summary, this is one more slide to show. Where do we go next? This took a lot of work. I mean, a lot of videos to record, a lot of algorithms to build. What if we can do this through AI? So we're not quite there yet like this, but I'll show you what we've made progress in the last couple of months. The concept is called vibe coding. Vibe coding is something that everyone should know how to do on this call within the next year. It's the idea that you literally could just talk in normal terms, and even literally, I know no tech, and I built 5 apps in the last couple months that do pretty advanced things that needed to be solved for me. I think the future, by the way, is that everyone's going to be vibe coding and there's going to be precision automation tools for everyone's individual life instead of just buying apps that other people made. But I vibe coded, could I create an app that did this, but in audio only, not video? I'll explain why. But here's a video of me explaining the concept. I believe that the best way to learn is by getting things wrong and seeing what happens. That's why residency works. We make a lot of mistakes. I did my best to attempt to make an oral board simulator or a case scenario simulator that takes you through a case, and if you get it wrong, it will not tell you. It'll just take you through that scenario, and it will keep going. It'll be different every time. I'm ready.
Let's get started. You have a young adult patient brought in with a single stab wound to the abdomen just below the umbilicus. The patient is hemodynamically stable for now, but there are signs of peritoneal irritation. What do you think is happening internally, and what is your initial management plan? What is your next step?
If he's got peritoneal signs, I'm worried about a visceral or bleeding injury. First thing I want to do is assess his airway, his breathing, and make sure his vitals are okay and see if he's still hemodynamically stable. And I'd get 2 large bore IVs in place.
So you decide to focus on the ABCs first. After doing that, you find that the patient remains stable, but he is starting to have more abdominal tenderness, vein guarding. What do you think is happening and why, and what do you want to do next?
I still think that there's probably an injury, but he's stable. What I would like to do at this point is take him to the operating room for a laparoscopy.
So you decide to take him to the operating.
And the best part is, if you make a mistake, it doesn't tell you you made a mistake. It literally takes you down the path that would have happened if you made that mistake, so that you will see what happens to a patient when you do the wrong thing. So it's better than just the right answer. So in conclusion, we do have to embrace whatever the flavor of the year is of how people are getting information and adapt. We need to do better with adapting to the trends of how information is spread instead of sticking to the old traditional ways we believe we've always done it. And together, we can democratize knowledge around the world. Thank you so much for the time. I think we have a few minutes for questions, if there's any. Oh, I'm supposed to read them. That's right. Sorry. Let's see. Well, I don't see questions, but I'll wait a couple minutes and then if not, we could end early. Oh, if you're a single person education team. Oh, great question. Okay, so if you're by yourself, first of all, you're welcome to join our lab. We do it every week and people come from all over, so you could kind of do your own thing and hear what we're doing. So just reach out. What I would say is the beautiful thing about this is how easy it's becoming. So to start creating videos and stuff like that's too hard. But you can, I just put a video out yesterday of how to make an infographic. That's one way to start. If you want to make videos, there's really easy ways to make a video every day that will take you 5 minutes. It won't be Hollywood level, but it doesn't need to be. And then start finding others. There's groups. I have to figure out how to work with other people. I'll have to be honest. I'm really excited about this group here because I haven't been able to find who are my people that do this kind of thing. Like, who are the other educators, people interested in sort of innovation education? I've never been to an innovation education meeting. So I think together we should figure out how to do this together. And I definitely will learn more from you than I'll be able to teach you, but I don't know if that's a good enough answer, but there's a lot of ways to start small. So yeah, there's a lot of, the one fun thing that helped me build my team is social media gets the young people seen and heard, and they were all able to, I think it really contributed to them getting into their residency programs, getting into things because people knew them when they went to interview. So for young people who are interested in a project out of a senior project, a college project, this is a great thing to give them work on. So I think if there's no, let's see, is joining your lab the Substack? Oh, no. So Substack is what we just realized is it's a great way to, if you don't go on social media, it sends a newsletter once a week of all of like the top 3 things you should know about. So it's more of like a social media, there is a social media site, but we like it because it's just easier to digest as a newsletter. And you can go on and find people and it just sends it once a week. The one on the left, that's my email. And I think that QR code gives you my email, but also like the different social media channels with all the videos. So just email me. Let's see. Have you found any platforms blocked? Oh, okay. So for social media, no. everything works in our hospital social media wise. I mean, I haven't tested them all. But no. Okay, so let's do a few things. I'll tell you what is blocked is a whole nother thing. We're trying to build an AI automation team so that we can automate our hospital. That's very hard in a hospital to do that because everything's private. So you have to only use things that that work within the private structure of the hospital. As far as viewing content, everything is accessible. ChatGPT is not blocked in our hospital, but if we're doing anything related to patient information or related to work, we have to use the hospital AI system, which is 𝗏𝗏𝗃, but it has ChatGPT built into it. But no, it is not blocked. So I think that's it. We have a yes. So almost every organization, definitely every hospital has their own system. If you email me, I can kind of talk you through who to talk to. But for us, we're a Microsoft hospital. That means everything's Microsoft. So it's going to be Copilot. Our automation system is called Power Automate. Everything's within the Microsoft space. However, if there's something that's not, your IS team can usually bring something into your hospital private tenant. So we've asked them to put things like Claude and others that we don't have. We put them inside our safe environment in our hospital. You can also now download ChatGPT models onto your own computers. Yes, the functionality is definitely decreased. It's very frustrating. It's frustrating me. We got into an argument today at work just because I feel like we're going to be so far behind because we're so limited with what the hospital allows. Yeah. Again, Copilot is getting better, but they can now have plugins. So Copilot can have a ChatGPT plugin. And again, I use it every day, ChatGPT or Claude or Perplexity. I use them. I just don't ever put any private information in it. And the agents, like if you've noticed, just come to the next workshop, we'll show you. But Claude and ChatGPT can now reach out and check your email and check your calendar. That's not going to work, obviously, from your private organization. It's very limiting. So I think we're, yeah. You'll see. I think it's going to get better. But the good news is our head of IS is very supportive of trying to figure it out, but we do have to be careful also. So I understand the delay, but I really appreciate everyone's time here. Very, very cool stuff, and I'm glad I'm talking to the right group here. So thanks for letting me present here, and just reach out anytime.